Hey everyone, this is Vaibhav Shandela from ASIC Medical College, and today we'll be talking about our one of the final bloodstream infection topics, major topics, which is Salmonella. This is short an essay question or a 15-mark question, and which is why it is very extensive, and we'll be covering a whole lot of headings, and everything will have something important you'll have to remember. So let's start with the introduction. So Salmonella is a gram-negative organism belonging to family Enterobacteriaceae. Okay, easy to remember, gram-negative Enterobacteriaceae. It is of two types, typhoidal salmonella, non-typhoidal salmonella. Typhoidal being more important, obviously. Non-typhoidal, the only thing you have to remember, causes gastroenteritis. Gastroenteritis meaning anything related to the bowel problems, vomiting, nausea, diarrhea, everything. Just the gut. Coming to typhoidal salmonella, we are further dividing this into Salmonella typhi and Paratyphi A, B, C. There are three paratyphies, just one typhi. Typhi will cause typhoid fever, while paratyphi will cause paratyphoid fever. And together, both of them are referred to as the enteric fever. Right? It is not the Salmonella typhi or typhoid fever alone which is called enteric fever. The paratyphoid fever is also referred to as enteric fever. You need to remember that. Okay. Now coming to the Salmonella is a genus, right? This genus Salmonella, based on the O antigen, which we'll discuss about in just a moment, it is divided into around 67 serogroups. Based on the H antigen, the second important antigen, it is divided into around 2500 serotypes. So genus Salmonella, O antigen divides it into serogroups, H antigen divides it into serotypes. Serogroups, then serotypes. Coming to the antigen, so antigen protection, like the antigen expressed by Salmonella, there are three types: H antigen, O antigen, and VI antigen. So let's discuss in detail. H antigen is also known as the flagellar or H antigen, which appears later and disappears late during the course of the infection. What this means is that late meaning it will appear in the convalescent stage of the disease, meaning during the recovery stage. When the infection is just about recovering, you'll see this H antigen pop up around. Okay, and this is definitely more immunogenic, which will be important in the lab diagnosis, right? And it expresses a protein flagellin, which is responsible for motility. Hence, the flagellar H antigen, more immunogenic, responsible for motility, comes in the recovery stage. That's it. Coming to somatic or O antigen, it's called the somatic or O antigen. It appears early and disappears early, meaning it will indicate recent infection, right? But it is less immunogenic compared to H antigen, means it will be less significant in the lab diagnosis, although it is part of the lipopolysaccharide cell wall. Okay, so this was O antigen. Coming to the final VI antigen, this is poorly immunogenic. So it will be not at all be used in the lab diagnosis, although it covers the O antigen. So the VI antigen will cover the O antigen, and hence it's also known as the envelope or the capsular antigen. That's the only important thing. So we've got the three antigens which are expressed by the Salmonella organism. Let's see the pathogenesis of how it infects us. Transmission is by oral route, contaminated food or water, and the minimum dose for infection, the infectivity dose, is 10^3 to 10^6 bacilli. You need more than this for infection. Easy. Coming to the risk factors which will cause the infection more likely, you need to know that Salmonella is acid labile, meaning acid will kill Salmonella. So any condition where this acid is decreased will help proliferate the Salmonella, correct? So this can be when there is decreased stomach acidity or the intestines are not working properly, intestinal integrity is gone. So decreased stomach acidity can be seen in overuse of antacids, right? Achlorhydria, H. pylori infection, all this will mess up with the stomach's original acidity, hence increasing Salmonella. Second, we have intestinal integrity can be compromised when we do any GIT surgery. We're exploring the whole body, the GIT that can hinder it. IBD, when you're going through IBD, then you can decrease the intestinal integrity, and this will be a risk factor for Salmonella. Now coming to the real pathogenesis, the process. So when the Salmonella infects us via an oral route or contaminated food or water, it actually comes in contact with the M cells on the intestinal mucosa. So the intestinal mucosa will have these M cells, and the salmonella itself triggers formation of certain membrane ruffles, or simply known as vesicles, on the M cells. So we'll have membrane ruffles or vesicles on the M cells because of the salmonella, which will eventually engulf the salmonella. Engulfing the salmonella, as you can see, this process occurred because the salmonella triggered it. So it's eventually known as bacteria mediated endocytosis. Mentioning this word in the pathogenesis will just fetch you marks. Okay. So this is bacteria mediated endocytosis because of the salmonella itself. The salmonella is then phagocytosed by the macrophages, but unfortunately, the macrophages cannot kill salmonella. Why? Because the virulence factor is it alters the lipopolysaccharide on its cell surface, because of which it becomes resistant to the lysozymes by the macrophages. It's resistant, so it doesn't get killed. It spreads via the lymphatics to the blood, spreads to the blood, and this is when it causes primary bacteremia. The general symptoms, the primary bacteremia. After a while, it will also seed into other surrounding organs, causing secondary bacteremia, these organs being mainly liver, spleen, gallbladder, kidney, lungs, and you'll see a whole lot of clinical manifestations, which we'll get into now. So this was pathogenesis. Coming to the clinical manifestations. The incubation period is 10 to 14 days, means this is the period required from infection to onset of symptoms, 10 to 14 days. Fever, very important. Why? Because there is a characteristic stepladder pattern of remittent fever. What does this mean? Remittent fever means the fever will never reach the baseline. Right? You'll never reach a normal temperature throughout your day. It will never reach the baseline. Stepladder indicating the fever will increase with each episode. Each episode increases the last plateau of the fever. It will increase the temperature, and it is never going to reach the baseline. That is what we mean by stepladder pattern of remittent fever. It will keep on increasing throughout the day. Next we have rashes. Rashes, characteristic rose spots will be seen where? Maculopapular rash only on the trunk and chest. Only on the trunk and chest. This is what you have to take away. Rose spots. These are the rashes seen. Other symptoms: headache, chills, cough, sweating, myalgia, arthralgia, basically whole lot of pain, headache, pain in the head, sweating, pain in the muscles, pain in the bones, everywhere it hurts, coughs, chills, you're just not well. Those are the other symptoms. Your intestine is also not working properly. You got pain there, nausea, vomiting, anorexia, GI bleed. Okay. What are the signs you can elicit? Hepatosplenomegaly in the abdomen, epistaxis, bradycardia, heart rate going down. Hepatosplenomegaly, epistaxis, bradycardia. You can also rarely see neurological manifestations. So you can see because of the secondary bacteremia, because of seeding into various organs, we're affecting a whole lot of systems. From fever, rash, to these generalized symptoms, to intestinal manifestation, neurological manifestations, and these abdominal signs, other signs, it affects a whole lot of systems. So this was the clinical manifestations. Let's go to the lab diagnosis, which is a major part of this discussion. So we'll divide this lab diagnosis mainly into what we should do in the first week of the illness, what in the second and third week of the illness, and what during the third and fourth week of illness. Starting with the first week of illness, our concentration will be on getting a blood culture. We need to know why we're getting the infection. Blood culture, we'll culture it where? On the blood agar. Blood agar will show non-hemolytic moist colonies. Non-hemolytic moist colonies. McConkey agar will show round, translucent, pale, non-lactose fermenting colonies. Let's just remember non-lactose fermenting colonies. Non-lactose fermenting. Non-hemolytic, non-lactose fermenting. This is blood culture. So do this in the first week of illness. We'll leave second and third for later. That is when you do the famous viral test. We'll discuss about this. Let's get to the final third or fourth week. When you're way past the infectivity phase, third or fourth week, what do? You do stool and urine culture. You try to find the organism in either the stool or the urine. What will you do? You want a highly selective media which will short give you a diagnosis. You do DCA, XLD or Wilson-Blair. Understood? DCA. What will DCA show? Deoxycholic acid. non-lactose fermenting colonies with a black center. Non-lactose fermenting, as you saw in the McConkey earlier, with black center. What will XLD show? Red colonies with a black center. Again a black center, but this time in XLD you'll get red colonies, right? And what will Wilson Blair show? Wilson Blair different for typhi and paratyphi. Why? Because typhi produces H2S. H2S means like it is generally in microbiology related to the black color. So you'll get jet black colonies because of this with a metallic sheen in the Wilson Blair test. Wilson Blair media. Jet black colonies, metallic sheen with typhi because we produce H2S. Paratyphi on the other hand will not produce H2S, so you just get plain green colonies, not black colonies as in typhi. Okay, so this was the highly selective media, short diagnosis. Low selective media can again be McConkey, and we know what we see in McConkey. This is a low selective media. We can also do an enrichment broth in a celerite F broth or a tetrathionate broth. These are the two broths you can remember. This is what you do during the 3rd and 4th week of illness. Let's talk about what to do in the 2nd to 3rd week of illness when you get the infection 2nd to 3rd week from the illness. Very important because here we dive into viral test. Viral test is very important. You can get this as a 5 marker individually on its own. Let's discuss. What's the principle behind the viral test? Agglutination test. Meaning we're trying to detect H and O. Remember H and O are the antigens. We are trying to detect antibodies against these antigens. H and O antibodies are detected by the help of H and O antigen. This will get definitely clear here in the procedure, but let's just see which antigens are used for this test. Basically, we're adding these antigens in the blood of the patient and see if there are antibodies present or not, which we'll see by agglutination. We'll discuss this in procedure. The antigen used are O antigen of Salmonella typhi is referred to as TO antigen. H antigen of typhi, TH. H antigen of paratyphi A, AH, similarly BH. H antigen of paratyphi B. TO, TH, AH, BH. These are the antigens which are used in this viral test. What's the procedure? Patient's sera is diluted 1:10 to 1:640 dilutions. You just dilute the patient's sera, so you have more sample. Antigen which is used, we discussed above, these 4 antigens are used and these are added to this sera. So antigen added to the sera, and this is incubated at 37 degrees Celsius room temperature overnight. Incubated. If now you added the antigen to the sera, if the sera will have some antibodies, agglutination will occur, right? So if O agglutination occurs, this will present as granular chalky clumps. Okay, granular chalky clumps for O agglutination. If H agglutination occurs, if the flagellar agglutination occurs, large, loose, fluffy, cotton woolly clumps. Okay, it'll just be more large and fluffy. This will be more clumpy, right? That's the difference between an O agglutination and H agglutination, which we'll see in the viral test. When you added the antigen to the sera to note for presence of antibodies in the form of agglutination. Correct? The interpretation. How do you interpret this? What if we're getting an agglutination? So what? So if there is an increase in the TO or TH antibodies, this indicates that enteric fever has occurred because of Salmonella typhi. Yeah, right. Because TO and TH, as you can see, were for H antigen of typhi and O antigen of typhi. So if TO, TH elevated, enteric fever due to typhi. Similarly, TO and AH elevated, antibodies elevated due to paratyphi A. TO and BH elevated, paratyphi B. Only TO rises, that means a recent infection, because remember we said O antigen arrives early, goes early. Only TH rises means we're in the convalescent stage or recovery phase. Why? Because H antigens arrives late, goes late. I also said, as you can see, O antigen will be detected everywhere in all infections, which is why here in the pathogenesis, we already said it is less immunogenic. It will not help you distinguish between the type of Salmonella infection. While H antigen is more immunogenic. If you look at it here, H antigen specific to A, specific to typhi, specific to B. Correct. So this will be highly immunogenic. So this will determine what type of infection we're having. and what the course of action will be accordingly. So this is the interpretation of the Widal test. For some extra points, a false positive, you do not have the infection, but the Widal test shows you have an infection when you're priorly immunized. Obviously, if you have immunized, you have some kind of organism in you, even if it's weakened or killed. Other infection with previous history of enteric fever. If now you got malaria or dengue, but earlier you had enteric fever, then it can show a positive. False negative. It shows you don't have the infection, but you actually do. When you're a carrier, that means you're at subclinical levels. When the patient is on antibiotics, you're covering it up. Or prozone phenomena. Just a fancy word where excess antibodies are formed. In that case, it will give a false negative. You don't have to buy hard this if you don't want to. Just remember Widal test, the principle, the antigens used, how it's performed, and how to interpret it. And this is done in the second and third week of illness. Correct? What else do we have? Culture smear and motility testing. Culture smear and motility testing. Gram negative as discussed, non-sporing, non-capsulated. Okay, this was this. Coming to antimicrobial susceptibility testing. Where do you do this antimicrobial susceptibility testing? On Muller-Hinton agar via disk diffusion test. This is for a better treatment strategy. You do this on a Muller-Hinton agar disk diffusion test. Only if you can remember this. Muller-Hinton agar disk diffusion. Identification. How do you identify this organism? The famous tests we do. Maldita-Witek, obviously. There will be abundant H2S. This indicates typhi. Why? Because we clearly saw in Wilson's media, we saw jet black colonies. Remember, that was because of the H2S. So, Maldita-Witek will detect H2S in typhi. Other than that, this will be catalase positive. But catalase is the only positivity you will see. Oxidase, indole, citrate, urease, all negative. Just remember catalase positive. Everything else you can remember on the top of your mind, it's all negative. Oxidase, indole, citrate, urease. But catalase positive. Triple sugar iron test. TSI test. This shows alkaline by acid presentation and gas is present. What this means is, if you look into TSI test, there will be a slant and a butt. So, this will indicate that there's an alkaline on the top and the acid on the bottom. And the test tube. This is a test tube. So this is just, if you look at this video is not about the TSI test, but if you just look at some easy YouTube video, you'll easily understand the whole concept behind this. Basically, it's alkaline by acid for Salmonella. K by A. K refers to alkaline, A refers to acid. This was identification. Finally, last, slide agglutination test. For S. typhi, it agglutinates with O9 antisera. Paratyphi A agglutinates with O2 antisera. And paratyphi B agglutinates with O4 antisera. This is slide agglutination test. Just remember this. Some things we just have to remember. So this was lab diagnosis. Sorry. So quickly, before recapping the lab diagnosis, let's just see the treatment. It's just quick. Ceftriaxone, azithromycin, fluoroquinolones. Ceftriaxone, azithromycin, fluoroquinolones. That's the treatment. 3 drugs. No one asks treatment that seriously. You can just mention these. So let's kind of just revise quickly what we saw. Let's look at the lab diagnosis first, because this seemed very important. First week of illness, blood culture, blood agar, non-hemolytic, McConkey, non-lactose fermenting. Second and third week of illness, in order, Widal test, right? Which principal agglutination, antigens, 4 antigens are used. What do? Add it to the patient's sera, because we're checking for antibodies. How do we know if antibodies are present? There will be agglutination, O or H agglutination. And this is how you interpreted it. O was less immunogenic, so it will be present everywhere. H was more immunogenic, so it will be specific for paratyphi A, paratyphi B, or Salmonella typhi. Correct? False positive, false negative, that's fine. In third and fourth week of illness, what do? Stool and urine culture. Finally, you'll do this. How? Highly selective media, DCA, non-lactose fermenting, but black center. XLD, red colonies with black center. Wilson Blair, jet black colonies in typhi because H2S is produced, otherwise it's just green in paratyphi because no H2S. Low selective media, again McConkey, enrichment broth, selenite F tetracyanate. Apart from this, you can see that it's non-capsulated, non-sporing. You can do a Muller-Hinton agar for antimicrobial susceptibility. Identification, just catalase positive, rest all 4 negative. it's H2S will be abundant. And this was mainly the lab diagnosis. Apart from that, if you want to summarize this: H antigen, O antigen, VI antigen, we discussed this in detail. Pathogenesis, again, bacteria mediated endocytosis. Salmonella itself triggers the formation of these ruffles and then ingestion, so that's fine. So the clinical manifestation, it affects a lot of different organ systems. Here we had to remember the step ladder pattern of remittent fever characteristic, rose spot kind of rashes, and all these general features. So I think we about summed up Salmonella. If you just get a good gist of this, make this in your exams, I think you're definitely getting top notch marks. Nothing stopping you. So all the best, guys. I'm coming with 3 more videos soon. Hope you like it. Comment and do all that. Thank you very much. See you guys.